Apologies for that. Welcome to the meeting of the Health and Wellbeing Overview Scrutiny Committee. Just to remind you that if you've got a mobile phone, it should be switched off or in silent mode, and also that this meeting is being recorded and will be available on the Council's YouTube channel. So apologies for absence. I have Councillor Nisbet, Councillor Bowman, Councillor Hardy and Councillor Chicken. So any others that we need? No? Okay. So move on to the minutes of the Health and Wellbeing Scrutiny Overview and Scrutiny Committee from the 2nd of November 22. You've had the minutes. Are there any issues with the minutes? No? Can I just have agreement from Councillor Hill and Councillor Humphrey? Okay. Note the forward plan of any key decisions. There's nothing on that forward plan that affects our scrutiny. So unless you've anything to say, no?
No, it's just the report that's at this committee this afternoon, which will be going to Cabinet on Tuesday.
So we've seen it, right. Health and Wellbeing Board. So we've got the minutes of the Health and Wellbeing Board held on the 8th of September and of the 13th of October. They're attached for any issues that you might want to raise or look into here. Is there anything from the committee? I think most of it we've already looked at ourselves anyway, so do that. So, item 6 is the report of the Interim Executive Director of Public Health and Community Services.
Declarations.
Oh, I've missed one. Apologies. Stop. Go back to, I missed the declaration of members' interest. So does anybody have any declarations of interest on any items on this agenda? Nope. Sorry about that. So the report of the Interim Executive Director of Public Health and Community Services. We've got the Drug and Alcohol Treatment and Recovery Service for Northumberland, the permission to tender. So I think John Little, who's our senior public health manager, is going to introduce this item. Thank you, John.
Thank you, Chair. Thank you, Chair. Okay, so I'll be fairly brief because there's quite a detailed report in the papers, which I'm hoping everyone's had a chance to have a quick look at. So just to kind of summarise, this is the asking permission to retender our drug and alcohol treatment and recovery service. We're proposing a total of a 6.5-year contract for that service. That's 4.5 years to begin with the option of a +2, which is an arrangement I'm sure you're familiar with. The current contract ends at the end of September of next year, 2023. We've had a number of kind of extensions added onto that contract. First one really was we extended it during COVID, which was it just made sense from a kind of a patient safety point of view, just to not kind of go through the disruption of a recommission during that period. There is an uplift to the current contract price. The current contract price has been in place since the current service started, which was 2014, so 6 years without any uplift in that period. 8 years actually, isn't it? Sorry, I've got correct. So 8 years, sorry, apologies. So we are proposing an uplift to that contract. I don't think, Chair, I don't know unless there's any questions. I'm not going to kind of go into a huge amount of detail unless people want to ask anything about the service or have any questions.
I'm sure we have.
Yeah, of course, yeah.
Okay. So you're happy to take them?
Yes, absolutely, yeah.
Questions, committee? Councillor Dodd and then Councillor Hill.
Yeah, are we making any progress in getting numbers down? Are numbers rising? You know, this is £21 million. I know it's over so many years. Are we getting a grip of it, or is it just sort of expanding that beyond what we can really do?
We're certainly making progress with the people that are in the service. So the people that come into treatment, we do get some good outcomes with those people. I mean, we can evidence that our own service, certainly improves people's health. It reduces crime, it reduces their drug use, helps keep families together. It does all of that. We can evidence all of that. It's one of the issues is that there is use of certain substances within the community is undoubtedly becoming more of a problem. COVID nationally increased the amount of problematic alcohol use within communities, so we've seen an increased level of need within communities for alcohol treatment. We are seeing the emergence of crack cocaine in some of our communities as well. So those continue to be kind of quite significant challenges, which is one of the reasons why actually a recommission of the existing service is really timely, because we can slightly tweak that that contract that we have with them and that service specification to make sure that we're hitting the right kind of notes in terms of what we're doing with communities. But yeah, look, there is undoubtedly there's increased levels of harm within communities, but our service, I mean, I think its record kind of speaks for itself. It gets some absolutely fantastic results.
Thank you. It's just a couple of points following on from what Councillor Dodd said. I get the premise that reduction and treatment of drug and alcohol issues has many benefits, including cost saving generally. I haven't seen any evidence that spending this £3 million a year is creating specific benefit to us. Just the evidence of the cause and effect has been made, but not what this service specifically is benefiting and showing value for money. Do other local authorities have a similar service, or do they rely on the NHS, would be my second question. And a more specific one, in regarding the service provider at the moment, they struggle and shrug the shoulders a bit like other services about service to my area in the north, Berwick-upon-Tweed. So can you give the reassurance that them or anyone tendering for this would be sure that they have to fulfil their obligations covering the whole of the county, not just the more convenient central and southern areas?
Okay, so second question first. Yes, all local authorities have this type of service. Every local authority in England has a drug and alcohol treatment service, which will look largely similar to ours, actually. In terms of the first question about seeing the benefit, I mean, I suppose what I would point to is, there's national evidence in place that applies to our service and actually all services, where when you reduce someone's criminal behaviour and you improve their health, your local community sees the benefit of that, because local communities have less crime being committed, hospitals have less demand on their services, and we see all of that. So where our service would be no different to any other service, and where that evidence was kind of sourced from, we work very closely with the Department of Health and the Home Office around, kind of evidencing that we're meeting those targets. One of the recent developments is that we've been given some new funding, which will move into answering the third part of your question, actually. Some new funding from the Home Office to deliver the aims of the drug strategy. And that is going to apply more scrutiny to local authorities around basically what benefits are you bringing to your local communities. And actually we welcome that scrutiny, because we're confident that our service will deliver against that. So we need to get more people into treatment. We need to get more people leaving prison, coming direct into treatment. That's a really kind of a dangerous period for those individuals when they first leave prison. Very easy, people can drop back and become homeless or drop back into criminal behaviour. So it's really important that we get them into the service. We're going to be monitoring that. We've got a target around that. And we need to reduce drug-related deaths as well. So the scrutiny is there from the Home Office. So it's being applied nationally, but as I say, it's a level of scrutiny that I think we welcome, because it'll evidence and further justify why we have this type of service. The third party question is a really good one, and actually I was speaking to the service this morning along those lines. One of the things that we've done, and this has been kind of gradual, one of the things we've been doing recently is looking at the ways that we can provide a better and more comprehensive service to places outside the kind of the real main areas, such as Ashington and Blyth and so forth, areas further afield. So we're equipping the service with a means to do that. So sometimes it's quite basic stuff. We've funded a vehicle, we've funded a car for them to use, so staff don't have to use their own personal vehicles. So the Harm Min service has now got a car they can use to travel around the service. I was informed this morning that's been really well used to lease vehicle. We funded that. So we're also looking more at digital interventions. So we're funding, just agreed this morning actually, we funded increased kind of technology, laptops, tablets, that type of thing for service users and also staff to use. So people who live in more more outlying communities can still access the service. We've had some really good feedback during COVID from online interventions from people who couldn't travel. We've also started funding. Like I say, I'm going to run through a little bit of an itinerary here, but if you can just indulge me. Sometimes it's the smaller things that make a difference, and when we've asked the service users themselves about what would matter to them, actually it's things like bus passes, so people can get on a bus and travel to a service if need be without having to pay for it themselves, because when you've got no money, even the price of a bus ticket can be quite a substantial dent in your income. So we've funded a programme called Breaking Free Online, which is a national treatment programme that is, it's a packaged licence you have to pay for, but we funded that. And it means that people can access a treatment service from their own home and engage with people up and down the country. It's got a fantastic rate of success.
It's probably also worth saying that actually under the Health and Social Care Act, we've got a duty to provide public health services aimed at reducing the harms from drug and alcohol. And it's implicit in the conditions of the ring fence grant. So, you know, from a strategic and a local point of view, this is definitely a service that we need to continue to invest in. I think it's fundamental to our responsibility to reduce health inequalities and improve the health of the population. And it is absolutely aimed at reducing health inequalities because these are some of the most marginalised individuals in our communities.
Finally, it's just from a point of view of scrutiny committee looking for evidence, there isn't any sort of case studies or specific data. So you, as I keep saying, you're making the case rightly why we need this sort of service and how this service can benefit, but not exactly how this service is benefiting. Any stats or case studies we can cling on to show this is working. You're just telling us it's working.
I mean, I think we can certainly come back at a later date with some case studies, and perhaps scrutiny might want to, revisit the arrangements sort of 12 months into the new contract, and we can come back and talk about how well it's going.
Sorry, I was the next question then, I do apologise. I'll come back to...
Just sorry, Chair, could I just quickly add something to that, please? Yeah. Just in terms of case studies, just to offer you some small reassurance, part of the contract arrangements that we have with the service, where we meet with them every quarter, is that we don't just go through data and kind of financial reports. We actually ask them to supply case studies to us, which is for me is as important as the rest of it, because it gives a real good picture of how well the service is functioning. Part of the existing arrangement, so it wouldn't be a problem to bring those to a future date and share them because we already have them.
Councillor Wilczek and then Councillor Hunter.
Thanks, Chair. Just two questions. How will the cost of living crisis affect the service? Are we going to see number of projections go up with substance abuse? And my second question is, in the report it says we need to ensure we meet the needs of those who are currently unable or unwilling to address their dependency. How are we going to do that?
Okay, so the first one, cost of living. Yes, it has the potential to make the situation even worse. Again, this is an ongoing discussion that we have with the service. So we have a quarterly contract meetings with them. We also have, as I say, an ongoing dialogue with them. So I was just in touch with them this morning, and we discussed this. We touched on this. It's what it'll probably do is two things. It'll probably bring people who weren't previously suffering from substance misuse. It'll probably bring them into that sphere, because people will seek solace in something else. It'll also make the problems of people who are already suffering from substance misuse worse, because they'll just have less money, and like all of us, they'll just have they'll be kind of feeling the pinch. So the service itself is likely, as all services, as every business in Northumberland, will also be feeling the kind of the squeeze of cost of living. So part of the reason why we felt it was essential to give them a financial uplift was to help deal with that. We also have a conversation ongoing with them at the moment, is we asked them to come back to us with some, like a clearer picture about where they're most likely to feel cost of living increases, because the service is quite it's quite kind of building centric. It's involved around people coming together and meeting each other for as part of a kind of therapeutic relationship, of course, but it's not necessarily the kind of thing you can always do as a form of outreach. So staff have to be based somewhere, technology has to be based somewhere, they have to have the lights on, they have to have the heating on, so all of those things kind of count. We've got an arrangement with the service at the moment, and have done actually for a number of years now, where we can fund sort of utility bill top-ups with people who are in absolute crisis. So we're talking about people who have meters in their homes, where they have to use a key, they have to top up. If you don't top it up, of course, then your lights can go out. So where outreach staff are going into people's homes and there's no heating on, there's no lights because the electricity's gone off, they've got a small fund where they can add some money onto that meter to get the lights back on. It's just, I mean, it's a fantastic way of just engaging with people. Apologies, could you repeat the second part of the question?
It was
please?
just in the report, it says that we need to ensure we meet the needs of those who are currently unable or unwilling to address their dependency, which is obviously a difficult situation. So how are you going to do that?
Well, the main way is having a service that is absolutely accessible to everyone. So regardless of a person's background or the length of their substance use journey or whatever, the service has to be accessible to them. So what we've looked at in the last few years and what we'll look at as part of the new contract is looking at question relating to the one we got earlier about what's the need like outside of the system, is looking at the levels of unmet need in the community, who doesn't access the service and finding out why they don't, and just trying to make the service as open as possible to those people, because there'll be a reason why they don't access it. We know a lot of those reasons already, but there'll be a few that we've missed, and it's just about ensuring that we find those out and we make sure the service is there for them. We get a lot of people who come via the criminal justice system who initially their view of the treatment system might not be something that they're perhaps interested in. So we work very closely with the police to identify those people as soon as we can within their criminal justice journey and give them the option of accessing the service and make sure they have that information at their fingertips. So if they choose to access it, then that's fine. If it's at a future stage, they still have that information, and we keep reiterating that message. So we have the option for people to know about the service at numerous different points. So via hospitals, via the criminal justice system, via prison, via the adult social care service, via our youth service.
Thank you. To really follow on for that, it's how we identify people that probably don't realise they've got a problem, especially with alcohol and that. And I think it's how we identify and get the help in at the early stages before they've got involved with the hospitals, with the police. And it could lead to domestic violence, things like that, where people don't realise they've got a problem. I think it's how we can try and get the message out as to they have got an alcoholic problem, but they don't realise. Maybe just an odd drink every night or an odd bottle every night. It's how we can identify it quicker, because the quicker we can get these measures in, it protects everybody else. And it's not such a big problem, because the longer we leave it, it's a bigger problem.
Yeah, absolutely. And it's one of the areas that we work on is we work very closely with primary care, with GPs, because it's someone who is in that early stage of alcohol use, probably doesn't see themselves as someone who necessarily would want to go to a drug and alcohol treatment service. Could actually be quite scary, the thought of going somewhere like that. So we completely recognise that. So we have kind of other points of access where people get a little bit, following from the question, where people can kind of be picked up. Chances are someone will go to the GP. I mean, the classic example would be someone might fall over because of their alcohol use. They hurt their wrist, for example, to go to the GP. The wrist injury is diagnosed. There's a further conversation about how that came about. So alcohol use is diagnosed via perhaps a sort of an alcohol brief intervention from the GP. So there's lots of GPs across Northumberland who are trained to, and lots of primary care staff who are trained to deliver alcohol brief interventions. It helps you identify, it helps you diagnose it, and then you give some advice to that person and say, have you ever thought about treatment? It's quite light touch because people don't necessarily want to be corralled into treatment or necessarily told that they've done something wrong or they've got a problem. It has to be light touch. But the right messages are there, and then people are given that information, and the idea is that they then are allowed to go away and kind of reflect on that. And then when they come back, the system's ready to receive them and offer them any type of intervention that they need.
Probably worth also mentioning we've got an alcohol care team in the trust, and part of their role is to identify people who might be who might be drinking in a harmful way, and linking those into the Northumberland Recovery Partnership. So we're sort of trying to tackle it on a number of fronts.
Briefly, Chair, while ago, I'm going back a few years, the minimum price of alcohol was being booted around. In Scotland, I think it was in this county as well, but some people didn't want it. Is that dead in the water now?
No. I mean, it's separate to this service, of course, and it's a big area. It's not dead in the water. I think there's still an enormous amount of interest. I think Scotland has watched very, very closely to see how that's developed. We have good links with other local authorities who feel quite strongly about this. We actually commission an organisation who does a lot of research in this area for us. So, you know, we need some transaction, or, you know, we need some traction nationally, I think, on this. But no, I wouldn't say it's dead in the water. I still think, I mean, it's evidenced as, from what's coming out of Scotland, as being quite effective. So, as I said, it's separate to the treatment service, and probably deserves its own quite in-depth conversation. But no, it's still very much a possibility. Yeah.
Okay, just haven't heard about it for a while.
Right, any other questions? So this is quite a large amount of money, a contract. Is there anything that we feel is not in here? Anything you feel might be missed out?
Just
That we have
emphasise
to
again what
look at?
Liz has said, to get more, because there's nothing here that tells me the service is, from a purely evidence point of view, which need to scrutiny, that this service is working. I know, I have to be honest, and it may be part of the location issues, but the feedback I've had from the service hasn't been good, I have to be honest. So there's a bit of a leap of faith going on here, saying we support this money. So it would be good in future to get evidence and case studies. And you mentioned you asked them for case studies. Obviously, it's better evidence if you ask for a random sample to contact, so they're not just picking, because, you know, the better examples, there's people always fall through the system. So that's the point. It would be good to get more evidence and details moving forward.
Anything else before we finish this? So we have recommendations. So we need to recommend that we authorise the interim director. This will be for the cabinet. Recommend the recommendation of the cabinet is to authorise the interim executive director of public health and community services to proceed with the commissioning exercise for a value of £21,818,608, as outlined in the key issues section below, and request officers to bring this back. They're saying to cabinet. I think we'd also like to suggest it came back to here at some point, especially with the suggestion of the case studies. Are we happy to agree this report and to go to cabinet?
Agreed.
Okay. Thank you. Thank you very much. So, I mean, you're welcome to stay, but we're going to move on now to the work programme. So if you don't need to be, you don't have to be, but you are very welcome. Yeah? So we have the Health and Wellbeing Scrutiny Work Programme, which you've got in front of you. We need to just perhaps discuss what else you'd like to see on the work programme. But I'm going to hand over to Chris to lead on it.
Thanks, Chair. Yeah, I'd be interested to hear the thoughts of the committee on anything that they would like us to add to the work programme. We're sort of approaching the end of this municipal year, so we'll be looking to start scheduling stuff in for the next sort of 12 months from May. April and May of 23, we have the NHS quality accounts, which are quite usually quite in-depth sessions, so I wouldn't look to add anything else to the work programme for April and May. So yeah, like I say, looking forward for the next 12 months from there. I'd be really interested to hear the thoughts of members.
Councillor Hunter, then Councillor Hill.
Well, I was going to say the ambulance service and the waiting times, because I know I had a resident the other day that they were told the waiting time for an ambulance was 10 hours, so husband took them to hospital. And I think it's just, we've come the winter pressures, so it's a case of, and if there is strike action, I know there's still services going to be there with the nurses and the ambulance, but I think it's the winter pressures and the waiting times.
I think that's quite telling, because that's exactly what I was going to raise. And we did have this discussion before with the ambulance service about getting breakdown of data for other areas, and it is there's a big national concern, as Councillor Hunter said. So yes, I think we do need something more in the ambulances.
The other thing I wanted to raise with the committee is just prior to this meeting, Councillor Jones and I had a discussion about task and finish groups. And whether there were any particular areas the committee were interested in doing some really in-depth work in. And I think what Councillor Jones and I agreed was that at the January meeting, I will bring back a brief sort of scoping report setting out some of the areas that we could do task and finish groups on, and what they might look like. But obviously I'd be interested again in any suggestions that the committee might have around task and finish group work. I think addictions is possibly one that we could look at. Alcohol, drug, gambling, ambulance waiting times we could probably get quite in depth on. That's the other one. The future of social care, there's probably a lot of work we can do around adult social care, but on page 42 of the pack is the committee's terms of reference. So if there's anything that you feel falls within that, then that is something that we can probably look at doing.
Yeah. Councillor Dodd.
Yeah, Councillor Jones, you and I were at a surgery on Saturday morning, and we had an unusual someone giving a moan or a groan. And it's on about gambling. Because how can we ever think of policing internet stroke whatever? Because this complainant was complaining that the William Hill betting shop in Ponteland had closed. And I didn't know it had closed, but it was about 5 months ago. So he said that everything is now online, and we, you know, at least in a betting shop, you would see people getting into trouble, or he said he's missing out the social part of talking about horses. But I mean, there's an awful lot of people I know who, you know, betting on the football. Or where do we start with betting? Because it must be massive. At one time, we'd know there was a betting shop, and you could sort of not regulate, but you knew it was there. So I just wonder where on earth we start with that. As I say, I don't gamble that much, so I wouldn't know.
Oh, Councillor Dodds points out that he wasn't aware that the shop had closed, so I think we can take that one. So is that something we could add in?
Yeah, I think in January, if I bring back a generic report on the areas that we can look at, and then if members are interested in focusing on gambling, then we can look at the details, because you're right, it is a very big area, and I think it's a task and finish group we need to be focused on perhaps what areas we do look at. So it might be worth, if we did settle on gambling, that we come back with a proper scoping report with proper terms of reference and a timetable of how we're going to investigate that. But I think unless gambling is what members want to do, I'll bring a report back in January with some options.
Well, it is one of the addictions that doesn't get included. I think sometime in the past there was discussion on it, but it is, you know, and that's now hidden behind closed doors, isn't it?
But if you read the journal, you know, there was one story the other day where this woman had stolen hundreds of thousands to feed her gambling addiction. Now, how many of them do we not see? Or what, you know, that there is real harm going. I mean, it could be as big as drugs. Honestly, I do not know. But it seems so easy for people to just bet on their phones. I mean, as you say, in my going back 25 years before phones really got into the system, you wouldn't, if you wanted to bet, you went to the betting shop.
And the important thing about this is, as Richard Oz rightly says, that in the old days people would go to the bookie, they'd have to wait for another race, they might spend a week's wages, which wouldn't be great. But now, I mean, you hear of horror stories with the instantaneous and that people are spending, like savings. You hear horror stories, people spending 30 grand and stuff, and then, you know, the huge sums. So people literally in 10 minutes, half an hour, can destroy their life by spending ridiculous amounts of money. There's the fixed odds, there's those roulette machines, and it was an absolute crack cocaine of gambling. This is an absolute nightmare. So I think it is important.
Sounds like you do have a topic there. Yeah.
So would the committee be happy if I bring back a scope and report on a gambling task and finish group then in January? Yeah? Okay.
Councillor Humphrey.
Can we also look at like the number of dentists and things? I mean, I've got a load of people, or you're probably the same up north of the area. Yeah, I get a lot of people asking about, well, dental and doctor appointments, not so much, but dentists in Blythe. I think there's only one allowing anybody to register at the minute.
NHS England are on the work programme for March to come and give a update on their wider dental access strategy. And NHS England are currently reviewing their oral, I can't remember what it's called now, their NHS England's oral health strategy and how they commission services. So that should be reviewed in the next couple of months, and we'll get an update through that, and that's possibly the best way to deal with the dentists.
Councillor Humphrey, we did look at that in terms of the work programme, but actually it is due to come back to us in March, so if you're okay with that, we'll keep it at that, and then we'll have the up-to-date position. Yeah.
Domestic abuse services, could we have an update on how we're doing in Northumberland? The maternity services as well, and social isolation, loneliness. I don't know if we could have an update on that, I think especially with the cost of living.
Thank you, those are good topics. Yeah. Anything else? No, I think you've given us a good work programme there. Right, well, I think that's... Oh, no, it isn't, because we've got... No, I have no urgent business. Yeah. Oh, and is that the correct one? Yeah. I'm just checking because we're looking at changing the date of the next meeting. Yeah, because the date of the next meeting would have been the day after...
3rd January.
Yeah, 3rd January, which we don't want. So I hope you're all happy that it's now going to be the 10th of January. So that will be the date of the next meeting, 10th of January 2023. So with that, I shall say thank you very much and wish you all a safe journey home. Thank you.